So we'll go ahead and get started. So today we're looking at income tax subsidization. So that's a pretty interesting aspect of health insurance that has a pretty large impact that we will see. And then we'll look at some brief estimates of the demand for insurance. And then we'll talk about the overall effect of the tax subsidy on the entire healthcare sector. Then we'll briefly look at optimal insurance, and then briefly look at one other model. I'm not sure. It's not really models. It's only one. So one other model of demand for insurance. So that's where we're headed today. Oh, did I start recording? Yes, I did. Cool. All right. So this issue of income tax subsidization, right? Basically, health insurance is subsidized through our income tax system. And this largely happens through employer provided insurance, which actually accounts for most insurance. But if we sort of analyze the problem using modern economic analysis, the analysis basically comes to the conclusion that the employee ultimately ends up paying for the employer covered health insurance through lower wages, right? So in a sense, the health insurance is like a fringe benefit. And so the company can pay their workers less in terms of their salary because they're offering these other benefits like health insurance, right? So from it, kind of comes from a competitive model, equilibrium, basically. So why are we going through this extra step of having the employer pay for it if it turns out that the employee actually just ends up paying through it in terms of lower wages? And the real key here is the tax code, right? How the IRS taxes different things, income as well as businesses, right? So the main issue here is that the IRS doesn't tax insurance contributions by employers as employee income. So the IRS does not view that contribution from the employer as part of the employee's income, but rather it treats it as a deductible business expense. All right. So that's really the key difference, or the key determinant, I guess. Right. So, and basically what this means is that the cheapest way of providing someone health insurance is via the employer, because you're basically avoiding the taxes, right? Both the employer and the employee. The employer gets the benefit of having a tax deduction, and the employee has the benefit of not having that as a taxable income. And so in a way, it's kind of as if the insurance is purchased with pre-tax dollars, right? So in that sense, it's cheaper. All right, so if we think about relative to everything the employee might purchase with after-tax dollars, right? Because that's most things we buy is with disposable income, right? Income after taxes, right? So after-tax dollars. And relative to everything that they might purchase with after-tax dollars, comparatively, health insurance, when it's covered by an employee, costs only 1 minus T as much, where T is the marginal tax rate, right? So I think on average, the marginal tax rate is like 25 or 35% or something like that. Okay, so in that case, it would be 65 to 75% of the actual cost. Okay, so think about this scenario, right? Suppose the insurer, which I think in this case is the employer, pays a share S of the total premium cost, and then the employee pays the remainder, right? 1 minus S. And recall that we can define the premium as R, which is 1 plus the loading fee, right? L is the loading fee, times B, which is the expected benefits of the policy. And also recall that if L is 0, the insurance is essentially free, because the employee or the insured pays exactly the expected benefit, right? Okay, so if this is the setup, then the cost of the insurance to the employee is R times 1 minus S, because they're only covering a fraction of it, while the employer covers the other fraction. But um, the employer's share, right, is pre-tax dollars, right? So we subtract the marginal tax rate from 1. So S times 1 minus T times R is the employer's share, which again is not reported as taxable income, right? That's the benefit of doing it this way. And so essentially in this case, the marginal tax rate, T, is the subsidy in terms of the employer's share, right? So the marginal tax rate itself is the subsidy. Now, if we were to add the employees and the employer's shares together, and then substituting R from before into that summation, we can show that the effective cost of insurance, which your book just calls R, which is kind of confusing because R is defined differently just a few sentences earlier. So I called it R star to indicate that it's different. It's the effective cost, right? We can calculate the effective cost, R star, as 1 times the loading fee times 1 minus ST, S times T times the expected benefit. Okay, so if you want to convince yourself of this, you can do that. All you really have to do is add those shares that we just saw. Okay, so let me go back real quick. I actually had to do this for myself. The book is like, it can easily be shown. I was like, I don't see it. I'm gonna have to figure this out. So here's the employee's share and the employer's share. If you add those together and simplify and then plug in this for R, that's where you get this right here. Okay, so the effective premium. And like I mentioned earlier, if we think if L, the loading fee, is 0, then essentially the insurance is free, in the sense that the insured, right, the employee, pays a premium that's exactly equal to the expected benefits that they will receive, right? And in that sense, it's free. Okay, so there's something interesting going on here. So this subsidy, which is the marginal tax rate T, applies not only to the loading fee, but also to the entire portion of the policy that's paid by the employer. Okay, so the subsidy doesn't just apply to the loading fee, it applies to the entire portion of the employer's share of the premium. And there's some recent data now. Keep in mind, this book was published like in 2013 or whatever. So recent is relative here, but maybe 10 years ago or so, some data showed that on average, S was about 0.76, meaning that employers pay roughly 3/4 of the premium. And there's a lot of people that this is actually one, where the employer pays the entire insurance premium. And we can use the CBO's estimate of the effective marginal tax rate of 35% to kind of think about this a little bit more deeply, right? So the average marginal tax rate is about 35%. Now, since immigrants basically escapes this taxation, the tax system in the US essentially subsidizes over 1/3 of employer paid premiums. So a full 33% of these employer paid premiums are subsidized by the US tax system. And this brings up another issue, and that's for larger insurance groups, where the loading fee can frequently be below 10%, while the average subsidy for health insurance is 25%. So basically, it's as if the employee is getting paid uh, for having insurance through the company. You can think of it like effectively, the loading fee is negative, right? So that's kind of how you can think about it. So that's kind of interesting, right? So, and this is a system that is really unique to the United States. Most other countries in the world have some form of nationalized healthcare. So this employer-based insurance setup is really unique to the United States. Okay, so we mentioned earlier that using modern economic analysis, it should be the case that the share of the insurance premiums that the company covers, the employer covers, should be passed back to the employees in the form of lower wages. And this is really depending on a branch of economics known as general equilibrium theory, right? Basically, the idea is when things change in one market, it has a ripple effect in all of other markets, right? That's what general equilibrium theory is. It's very complicated because you have to analyze a single change having an impact throughout the entire economy, right? So the price of gas goes down, that's going to have an effect on almost everything in the entire economy, right? So analyzing that's called general equilibrium theory. But the insight itself is really not that difficult to grasp, right? So you can think about there existing some firms in the economy that don't pay insurance premiums at all, while others do. And in order to compete effectively against one another, the firms that pay for some or all of the insurance have to reduce other forms of compensation. And the most obvious one is direct income through either salary or hourly wage in order to stay in business, right? So again, it's coming from a competitive equilibrium model, um, which we know isn't always true, but if it is, then that's what we should expect. And this is even more true in an open economy where competition from abroad is part of the picture. And those companies in other countries, like I mentioned earlier, their employer-based insurance exists almost nowhere in the world except for the United States. So foreign companies don't have this burden. And so the competition is even more fierce when thinking about it in terms of international trade. Now, the advantage of paying workers with health insurance rather than dollars is the assistance that's given by the tax system that we've been talking about. Okay, so let's put some numbers to this to really start to digest it, right? So for every $1,000 paid in insurance premiums, even if it's fully offset by $1,000 less in wages or salary, brings with it a tax reduction of to the worker of $1,000 times T, right? Because if they're earning $1,000 less, and their marginal tax rate is T, then that's their tax savings as a result of getting the employer-based health insurance rather than earning the money themselves, being charged a tax, and then buying the insurance themselves, right? So, for example, if the marginal tax rate is 33%, then the essentially the bonus or the benefit to the employee is $333 for every 1,000 of dollars that is shifted from wages or salary to health insurance premiums. And this has actually had a pretty substantial effect in the United States. Okay, so we're going to look at table 10.3, where we've got data for 2005 and 2010, and there's also forecasts for 2015 and 2020. So it'd be interesting to see if the forecasts were even close. Unfortunately, I'm not exactly sure where to find this data. CMS medical expenditure estimates. So I'm sure we could find the current values and compare them to the estimates. But so your book focuses in on 2010. Okay, so where we can see that private employers spent 398 billion on health insurance premiums, um, and federal and state and local governments added 29 billion and 139 billion, 131 billion, sorry, respectively, which brought the total employer insurance payments to $558 billion. And then you can see that that was estimated to grow over the next 10 years, right? We can also see that individuals paid out of pocket 258 billion, which is down here, right? So individual payments. So you can see also individual plan premiums. These are plans that are not employer provided. So this is like self-paid insurance here. And then the employee share of employer plans, 179 billion for a grand total of $258 billion spent by individuals. Now, unfortunately, this figure doesn't break down into some things we might be interested about, but there is a separate survey from the health insurance industry, the AHIP, and they surveyed health insurance plans to get information on the costs of non-group insurance. And they found that the survey found that the premiums averaged just over $2,500 per covered life year, or covered life per year. And if we were to extrapolate those to kind of get an estimate for 2010, using, because this was 2009, right? So if we extrapolated those to 2010, the figures we were looking at, and we combined them with data from the US Census that showed that 30 million people were covered by non-group insurance, or in other words, they were part of individual plans, we can essentially estimate that the 2010 payments for individual insurance would have been 79 billion, which I guess is where this number comes from. Yeah, so that's this number here, this 79 billion figure is the estimate from this separate data. These other datas, this other data here was from the CMS medical expenditures estimate report. Okay, so what does this mean? It means that of the $258 billion in individual payments, 179 billion went towards the employee's share of employer group plans and premiums. Okay, so that's where, going back real quick. So the original data provided this number, but didn't break it down into these categories. So basically we estimated this value of 79 and therefore imputed the 179 remainder, $179 billion remainder. Okay, so this brings the total cost of employer group plans to $737 billion, 75, almost 76% of which was paid by employers. And hence that fraction, that 2/3, was able to escape taxation. It also means that roughly 30% of total individual insurance payments, that $258 billion figure, went toward non-group insurance, and the remaining 70% were payments towards employer group insurance. And so this split actually has been extrapolated to the other years in table 10.3. So that's where a lot of the estimates are coming from, is from this 70-30 split that seems to exist. Okay, so now that we have a good understanding of the magnitude of employer-based insurance, right? 76% of almost $1 trillion is pretty huge, right? So now we can start to think about the economic impact that this has. And what we're going to see is that the total dollars that are escaping income taxation represent a huge, well, not a huge, but a significant fraction of the total US economy. Okay, so to think about the impact in terms of tax receipts, in 2010, federal income tax receipts amounted to a 1.5 trillion, and Social Security taxes for about another 1.1 trillion. And using this 30/70 ratio to create a quick calculation, the $558 billion in employer premium payments represent a huge chunk of foregone income taxes, right? So the US government and state governments and local governments even. So most cities don't charge income taxes, but some do, like New York City charges an income tax. So this is the total income tax at all levels of government that is given up because of the subsidization for employer-based health insurance. So that's a huge chunk of money that we could either spend on something, create some public goods, or reduce our deficit and our national debt, right? So this isn't an arbitrary amount of money, right? So this has a huge impact. This tax subsidy has a huge impact. So this huge tax, this huge chunk of evaded taxes, or avoided taxes, I guess, not evaded. Evasion is illegal. Avoided taxes represents roughly 11% of actual income taxes collected, right? So a huge chunk, and an even larger proportion of Social Security and Medicare taxes. And another way to put it is that if the government chose to tax these employer-paid insurance premiums, the tax base would rise by 11%, and so would potential tax revenues. And of course, like I just mentioned, these revenues could be used to lower the federal deficit. They could be used to reduce marginal income tax rates, which would unambiguously, of course, stimulate the economy, right? If you remember back to macro, expansionary fiscal policy, part of that is reducing taxes, right? Or any combination of these things, right? And then if state and local governments would have comparable increases in their taxable income as well. Now, a lot of states have balanced budget requirements, so a lot of states don't have any debt like the U.S. government does, but so they wouldn't be able to like reduce their debt as a result of this increased income tax, but they would be able to provide more public services and goods. So a good question that this kind of brings up is, well, what's the limit on the demand for insurance in this setting, right? What's limiting the demand for insurance? One limit is the choice of group insurance. So with group insurance, basically the group has to agree on the plan because everybody gets the same plan and they all pay the same premiums. And so they have to agree on it, and typically they vote on it, right? So the group plan compromises over the interests of all these workers that are part of the group. And then, of course, they all have different preferences, right? Some are going to be older, some are going to be younger, and there's going to be different ways that their preferences differ. You know, so I mentioned age, for example, but there's other things as well. So the fact that the group has to agree on the insurance policy, despite the fact that they have potentially very different preferences, that acts as sort of a cap or a limit on the demand for health insurance. And a good way to think about it is that, right, every worker in the group pays the same premium, the average premium, and that's regardless of age or health habits. And so what this means is that younger workers who are generally healthier will find that an extremely generous health plan is too expensive for their preferences, even with the tax subsidy. And since they vote on the plan, the younger people typically act to help limit the demand for health insurance within group policies. So that's one way that the demand for insurance is limited, despite the subsidy, right? The other limit is related to something we've talked about before, and that's the welfare loss that's generated by extending coverage too far, right? So those triangles that we saw earlier in the chapter. And then, of course, as C approaches zero, full coverage, the welfare loss caused by purchases of medical care just gets bigger and bigger and bigger. And so even with a tax subsidy, it's typically preferable to quit before full coverage is reached. So this is another kind of more natural limit, I guess. Okay, so to think about this a little more, let's go back to the example we had earlier in the chapter where we were thinking about a consumer or an employee, same thing in this context, right? That is deciding whether to purchase insurance, and they kind of face two potential illness risks. One that's less severe and only requires 4 days in the hospital, with a higher probability, 30% chance, and a more severe illness that requires 9 days in the hospital, but at a lower probability of only 10%. What we've already seen thinking about this is that a moderately risk-averse consumer would have a net gain from purchasing insurance of $56 after everything is considered, including the expected benefits and the welfare loss and all of that stuff, right? So let's use this same scenario, but consider what happens if the same insurance policy is acquired through group insurance and the consumer's marginal tax rate is 30%. So in this scenario, not only does the consumer gain all of the benefits that we've previously seen, the $56, but it also the tax liability drops by 30%, right, or 0.3 times the insurance premium. Okay, so we could calculate that. The insurance premium in this example was $924. And so the tax savings would amount to $277.20. And this is huge compared to the $56 by itself, right? So it seems pretty clear that this tax subsidy could have a pretty profound impact on the decision to buy insurance, right? So basically, it would encourage a lot more people to buy insurance, right? Because depending on the person's risk aversion, right, this net benefit could be negative. But if there's a tax subsidy, the benefits from the tax subsidy might override that negative net benefit and encourage people that would otherwise not buy insurance to have insurance through their employer, right? Okay, so to see this, think about an otherwise identical consumer that is less risk averse than the first person we described. Well, what this means is that their risk premium would be smaller because they're less risk averse, right? So $70 rather than 220 in the original example. So first thinking about the absence of a tax subsidy, the net benefit of buying the insurance would be negative, right? Because the costs, which are the premium as well as the welfare losses and the expected value of $80, the net benefit exceeds the willingness to pay for insurance, right? Which is $840 in this case, plus the $70 risk premium of $70 for a total of $910. So the expected value is $910, while the premium is $924. So this person would not buy insurance without a tax subsidy, right? But if we then consider where there is a tax subsidy, we add in this tax benefit of $277, and then we can see that this insurance policy is now attractive, and the smart consumer would choose it, right? The net benefit would no longer be negative, right? And the effect of this is to expand the amount of insurance that people purchase. And of course, the more people that have insurance, the more people will demand medical care. Okay, so that's the overall impact. Now we should keep in mind here that the same thing can be achieved if the marginal tax rate changes, right? So we assumed a marginal tax rate of 30%. If that changes, then even our more mildly risk-averse consumer might not take this insurance policy if the tax rate were smaller, right? So if the tax benefits decrease, right, the marginal tax rates go down, then the tax benefits decrease, and then it becomes more likely that even with the subsidy, that this person wouldn't purchase insurance. Okay, so just to go over a numerical example, if the tax bracket was 10% rather than 30, the tax benefit would be much smaller. It would be $92 instead of 277. And this wouldn't necessarily be enough to cover the cost of insurance, right? So a smaller tax rate, while in some ways is beneficial to the consumer, it also means that the subsidy is smaller, and so the effective cost of insurance would go up. Got my animation out of order. Okay. Are there any questions about that? The income tax subsidy? We're going to talk about the overall effect on the healthcare sector in a second, but before we talk about that, we're going to look quickly at some empirical estimates for the demand for insurance. And these types of studies kind of are separated into two different approaches. So one approach is to look at the choices made by either individuals or groups, while the other approach uses aggregate data over time in a sort of time series analysis. And so in the time series aggregate data approach, um, those studies are estimating how total insurance premiums, and in this case, it's for the entire economy because it's aggregate data, right? How do total insurance premiums change when income changes or loading fees or tax subsidies, et cetera, right? So that's the aggregate approach. In the first approach, where the studies are looking at either individuals or groups, the differences in people's income, right? So the differences in individuals' income or groups' incomes allow economists to estimate how demand can vary by income, basically finding an elasticity of income type measure, right? Um, and then differences in the group size can generate variation in effective price as well. So not only do we have variation in income, but we also have variation in effective price. And so this allows us to estimate um, price responsiveness as well as income responsiveness, which is great. Okay, so we'll actually talk quickly about the income effects first here. Okay, so of those studies that use individual data, estimated income elasticities are generally positive, right? Which, of course, means that it's a normal good. As incomes go up, people buy more insurance. But typically, they are less than one, and that's for almost any measure of insurance chosen. Okay, so normal good, it's a positive number, but it's less than one, so it's relatively inelastic. There's not much income responsiveness according to these individual studies. um, Now, there is an issue here. Measuring the correct income can be difficult for a particular insurance chosen in a group setting, um, because we don't necessarily have the data on every individual in the group. We probably just have data on the group. And in that setting, the median worker's income is more important than any other worker's income. And this is mainly because of dynamics that are very similar to the political science model that we used earlier in determining the board of trustees preferences, right, for the hospital. It's basically the same thing, right? Remember, these groups are voting on insurance plan, and ultimately the person that matters is the median voter, or in this case, the median worker's income. Now, fortunately, right, the reason there's two different approaches here is that aggregate data, the second approach, can avoid this problem. Okay, and there's some examples of studies that have used the aggregate data approach. Now, in these, the income elasticity in these studies is typically more than one and may even be closer to two. Okay, so at the very least, we can say yes, this is a normal good, right? We're getting positive estimates for income elasticities. The individual and group studies are giving us lower estimates, while the aggregate studies are giving us higher estimates. So it's kind of um, it's not exactly clear where that difference is coming from. So um, there's probably been some work done on this since this book was published. So I'd be curious to see kind of the advancements in the literature related to this. But that's what we can get from that's what we can get from the data regarding the income effects. Is at the very least we know it's a normal good, and it may be slightly inelastic, but it could also be relatively elastic uh, with regard to income. All right, what about price effects? So this is a really important question. The price effects are an important question for policy, primarily because of the way that the income tax system subsidizes health insurance, right? Um, Now, unfortunately, the ranges of estimates in this literature is large. There's a large degree of uncertainty within the literature on these estimates. But it does seem that the source of the variation um, is related to the magnitude. The source of the data is related to the magnitude of the estimate. Okay, so I'm trying to think of what that means in terms of like uh, experimental design, or I'm not really sure. I'll think about it a little more and maybe I can elaborate on that. Um, but we're still thinking about these two different approaches, right? The aggregate approach and the individual or group approach. And the aggregate data typically provides an estimate around negative 1.5 to negative 2, right? So of course it's going to be negative, law of demand. Um, and it seems to be relatively elastic, right? So that's the aggregate studies. Um, while the individual studies, right, the studies of individuals or groups have found quite a variety of findings. Um, and particularly when the size of the work group is used to generate price variation, the estimates are also typically large in the range of -1. So not terribly surprising, some relatively elastic responses here to price. Now, there are some other studies that use differences in marginal tax rates across households to try to determine the effect of price on insurance demand. And those studies get a much smaller estimate. It's almost zero, right? So negative 0.2. So a lot of variation in estimates here. It's not exactly clear which method is the best, which method is providing the best estimate. So that is unfortunate. But like I said, there's probably been some work done in these areas in recent years. So there's another piece of evidence regarding the price effects that kind of comes from, well, not kind of, it comes from the tax cuts that were initiated by the Ronald Reagan administration in the 1980s. And basically, they cut marginal tax rates, right? Well, we talked about this earlier. What happens when the marginal tax rate is reduced? Well, that means that the tax subsidy is also reduced, which means it's going to motivate some people who are kind of on the fence to switch from having employer-based insurance to not having it, right? Those people that are less risk averse will stop having insurance. And sure enough, that's exactly what happened, right? The number of people with hospital insurance began to fall the following year, right? The year after the tax cuts took place. So peak enrollment in these types of insurance plans occurred in 1982. 188.4 million people were enrolled on employer-based health insurance plans, and this fell to 181 million by 1985, and then fell further to somewhere between 165 and 170 million people in 1995. So that directly supports the model we were using earlier, right? That was the exact prediction. And this was actually the first time since World War II that there was a systematic decline in the number of insured people. Um, and we have to keep in mind too that this decline took place while the population was growing, employment was improving, as well as income was improving. So um, all three of those things should act to increase enrollment, but we saw declines, which means that this impact was relatively strong. We can look at the same picture sort of in a different perspective. So in the early 1980s, about 90% of people under age 65 had private health insurance coverage. And by the early 90s, that had fallen to 72%, so a decrease of 18%. So it seems pretty obvious that price matters, right? Uh, which shouldn't be surprising. Some studies say it matters less, right? Those group settings, those group studies estimated that 0.2 elasticity, while others have estimated elasticities as high as 1.5 or 2, right? Um, so unfortunately, while we can say that price matters, it's hard to say how much. Um, and nothing is comparable to the Rand health insurance study. Nothing like that is in existence, unfortunately. That was the only time that kind of study occurred. And really, that's kind of the best source of data because it was a randomized control trial, right? All these other things are just using data. They're not experimental. It's not randomized control trial. At best, it might be a natural experiment, but that's the best case scenario. In all other cases, it's just data that we've collected and so we can't really control for all types of unknowns. So so while we can say that price matters, it's hard to say how much, right? All right, so let's talk now about the overall impact of this tax subsidy on the entire healthcare sector. So it turns out that the cumulative effects could be quite large, and this was according to a study done by Vogel in 1980. And this is primarily because the health insurance subsidy produces secondary effects in the market for medical care, um, primarily because it increases insurance coverage, which in turn increases the demand for medical care. So that's the secondary effect, right? So it seems like there could potentially be quite a large impact. And in particular, the leverage that this interaction can generate has the potential for substantially altering the shape and size of the healthcare system. And in fact, it probably has had quite an impact on the size and shape. Shape meaning like, the how it works, right? The mechanisms and the institutions. All right, so to look at this issue a little more closely, Phelps in 1986 estimated that these employer group health insurance premiums would be only about 55% as large today if the tax subsidies were not in effect. So that's pretty substantial, almost a 50% increase because of these tax subsidies. Um, Now, cutting these premiums in half is not as radical as it might seem. Okay, so to think about this, go back to the fact that for a simple insurance policy, the premium is one plus the loading fee times the insurance coverage, right? The fraction of medical payments covered by the insurance, which is 1 minus C, times the medical expense, which is the price of medical care times the amount of medical care. And that, of course, the amount of medical care consumed falls as the coinsurance rate rises, right? So remember that. So if we use estimates of how medical care use varies with coinsurance rates, an increase in the coinsurance rate of about 25 to 30 percentage points, so say from 0 to 0.25 or 0.25 to 0.5, would cause premiums to fall by this amount. So that's not a huge, that's not very radical, right? That's not terribly radical. Although it does have a seemingly radical effect, right? A 50% reduction in premiums. While at the same time, this change, right, this change in insurance coverage, this roughly 25% percentage point increase in C would cause the demand for medical care to fall among people that are insured. And going back to the RAND health insurance study, it was telling us that demand is about 20% lower for a coinsurance rate of 25% than for a coinsurance rate of 0%, as well as 10% lower roughly for the coinsurance rate of 5% versus 25%. And what this is telling us is that total medical care could decline by somewhere between 10 and 20% among persons under the age of 65 who are insured through their employer or through this mechanism. And not only that, but if private health insurance had contained higher coinsurance or deductibles from the offset, without the tax subsidy, of course, the structure of Medicare would probably reflect that difference as well. Because Medicare was primarily patterned after private health insurance when it was initiated in 1965. And it provided essentially full coverage for hospital care, as well as a major medical type of insurance for doctor services. And it only had a $50 deductible and 20% coinsurance. So the outcome would be pretty similar in Medicare. But because Medicare is government provided and employer-based health insurance is not, private insurance with greater cost sharing would probably lead to public insurance with more cost sharing as well. So they would kind of match each other. Oops. All right, so what is the aggregate or total effect of this, right? Well, it seems like that the healthcare sector would be at least 10 to 20% smaller without this tax subsidy. And although this might seem small, we can translate this difference into something that, in terms of gross national product, it would represent anywhere from 1.5 to 3% of gross national product. And of course, gross national product, at least today, is somewhere in the ballpark of $20 trillion, right? So we're talking about, what is that? What's 3% of that? Like 600 billion, I think. Yeah, $600 billion, right? That's huge. So that's not small at all, right? So there's a really large impact as a result of this tax subsidy. Okay, any questions, you two? I'm not sure where everyone else is. All right. So now we're going to look at optimal insurance, or quote unquote optimal. So far we've been using the expected utility model, and it gives us all sorts of insights into the question of how insurance contracts might look, either with or without the tax subsidy in place. But particularly here, we're thinking about without the subsidy, right? Yeah, so I'll just move forward. So this model was developed by Kenneth Arrow in the early 60s, right? So this is a long time ago. And his model assumed that there was a consumer seeking to maximize expected utility, so really nothing different so far, and that consumer would select a policy with full coverage above a deductible when the losses are fully random, essentially, right? In no way correlated or in correspondence with the insurance coverage itself. He assumed pure randomness, essentially. And in this model, the size of the deductible increases as the loading fee increases. He was also able to show that the optimal policy would have a coinsurance feature included when the insurance with the wait, what am I saying here? Sorry. Showed that the optimal policy has a coinsurance feature included when the insurance company is risk averse. So this is where his model is a little bit different. So previously we assumed that the insurance company is risk neutral. And he kind of asks the question, well, what if the insurance company themselves are risk averse, right? So Keeler actually took this model. So Kenneth Arrow's work was purely theoretical. It was all just math from preliminary assumptions. But Keeler was able to use this model and estimate the expected utility among a variety of insurance policies based on the RAND health insurance study results. And what Keeler found was that the best plans, or something that's close to optimal at least, all contained a coinsurance rate of about 25% with an initial deductible of $100 to $300. And we can compare that to deductibles in 2010, where they were basically twice as much. Okay. So as it turns out, most current health insurance plans that pay for doctor services out of the hospital, so outpatient services, have this structure, have this more optimal type structure. And in fact, in a survey of employers, only 5% of covered employees had plans with no deductibles. More than half had deductibles in excess of $150. So really what we're talking about here, because up to this point, we've really only been considering this very simple insurance where there's a coinsurance rate, right? But most modern insurance has typically a coinsurance rate as well as a deductible. And adding this aspect of a deductible actually makes the insurance more efficient. So this theory of demand for insurance, coupled with the empirical results from this health insurance study, basically are suggesting that consumers would be better off with less complete insurance or less complete coverage. Okay, so that's kind of an interesting result, right? We have risk averse consumers buying insurance, and they would actually be better off with less coverage. So that's kind of an interesting result, right? And in that sense, it's more optimal, right? What's even more interesting is that if we got rid of the income tax subsidies, it would move people in that direction. And furthermore, the size of the change from full coverage to a major medical type of plan with these deductibles would correspond with the premium changes that are predicted to occur. And in fact, that's what's found, right? The shift towards higher deductibles followed closely behind the decline in the marginal tax rates that we talked about following the Reagan administration tax cuts. So when that subsidy declined, there was a shift towards charging higher deductibles, in other words, right? And in a similar study, only 10% of all covered employees had deductibles greater than $150, compared with 55% in 1990. So more evidence that the reduction in the subsidy increased deductibles. And as we just discussed, this actually improves the outcome for patients, for employees. All right. And lastly, this other model, not plural, of demand for insurance. I'm sure there are other models. In fact, I could talk about other models related to this one, and maybe I will because it looks like we have a little bit of extra time. So, but so far we've been using sort of the classic expected utility model, and it's really popular, right? It's a really popular way to analyze these problems, as well as other problems involving risk. But there are some downfalls with it, particularly regarding the precision of its predictions and how people behave in settings where there's uncertainty. So there's tons of experimental research on this issue. In fact, this is something that I was specializing in at Georgia State. So the strongest challenge in this regard has come from psychology. Two psychologists, Kahneman and Tversky, developed a new model of risk. And these guys, I think one of them is an economist, the other is a psychologist, if I'm not mistaken. But they were conducting lab experiments, facing subjects with choices under risk, and they were finding they were finding things that were incompatible with the expected utility model, and so they developed their own model, which they called prospect theory. Today, it's called cumulative prospect theory. So their original model has evolved a little bit. The current model is called cumulative prospect theory. And really what it's doing is it's getting rid of the assumption that utility functions are stable, or in other words, that it doesn't change, right? So that's really what's at heart of their model, is that they're getting rid of this assumption that utility functions are stable. And rather what they're assuming is that your utility function will actually depend on your perspective. In other words, they're providing us with a model where deviations from today's world affect behavior. So let's see, I think the best way to describe this is, well, so in their model, everything is viewed in terms of where you start from or where you are currently, and any change to that state can affect your utility function. And this is what they call the reference point. And really the easiest way to think about their model is that it allows for what's called loss aversion. And the idea is that losing $10 reduces your utility more than the utility you would gain from gaining $10. And in that sense, losses hurt more than gains feel good, okay? And thus the loss aversion. And the way that this is mathematically worked out is that people that are loss averse put higher probabilities. They weight the probabilities of something. So, um, let's say that there's a 5% chance that you're going to get some form of cancer and die. Somebody that's loss averse, um, and that's the objective probability, right? The objective probability is 5%. Someone that's loss averse would feel as if that percentage is higher, right? They would feel as if that 5% is really more like 10 or 15%, right? Even though it's not. And so it's called probability weighting. And that's how it mathematically kind of comes. Um, okay, so again, this whole view is coming from the fact that, or from the idea rather, that one's perspective alters their decisions and attitudes towards risk. So a good example of this is regarding state lotteries like the Powerball and Mega Millions, right? So standard expected utility theory predicts that no one would ever play the lottery, but of course, millions of people do. And of course, that prediction is coming from the fact that the expected value of the lottery is always negative. That's how lotteries work. It's the same thing with gambling at a casino, right? Um, in prospect theory, though, the consumer's response or choice to a gamble like this is going to depend on their probability weights and their frame of reference. And so, in the same way that people might overweight bad probabilities, they can also overweight good probabilities, right? So in this case, in terms of the lottery, people are thinking, "Oh, well, it says on the back of the ticket that my probability of winning is only 0.0001%, but I feel like I've got like a 5% chance of winning," right? That's kind of an extreme example, but that's the idea, right? They're overly optimistic. They're optimistic about good outcomes and pessimistic about bad outcomes is the main idea. Okay, so in this approach, people overweight low probability events like lotto gambles and those sorts of things, and so they appear more attractive. So this model, um, people playing the lottery is not inconsistent with this model, but it is inconsistent with the expected utility model. And there's other models that are similar to this. There's one called rank dependent utility that is similar. It also incorporates probability weighting, but it doesn't include loss aversion. And there's one other one that I can't remember. Anyway, there's another one that's similar to those two. But if you're interested in that, maybe I can convince the econ faculty to let me teach a class on risk. Um, or behavioral economics. That would be something I talk about in that class. So that's kind of like the frontier of this research is using other models other than expected utility theory, primarily prospect theory. All right. So to summarize everything we've learned in this incredibly long chapter, um, of course, health insurance is a way to protect against financial risk. And primarily or predominantly, I guess, economists use models of expected utility theory. And for the most part, that model can predict a lot of behavior, right? It's really good at predicting a lot of behavior, but not all behavior, which of course is where prospect theory was born. We've also seen in this chapter that most insurance in the country today is provided by employers through group insurance, and that this has the added tax benefit of the tax subsidy we discussed, right? And in some cases, the tax subsidy is sufficient to to alter a person's behavior with regard to insurance. Um, Additionally, health insurance is creating basically a subsidy for medical care, and that's when we saw that welfare losses emerge, right? Because the patient pays a lower percentage of the total medical care costs, and so they essentially overconsume medical care, and that leads to a welfare loss. Um, right? They're in a way kind of tricked into buying more care than they need, right? And this is an added cost of insurance that doesn't show up in any sort of accounting record, right? It's an implicit cost as opposed to an explicit cost. But it is a real cost, right? At least for economists, not for accountants. Right? Remember the difference between accounting profit and economic profit from micro? Accounting profit only takes into account explicit costs, right? Costs that have a receipt where there's actually money exchanged. And then economists consider not only explicit costs, but also implicit costs, which are things like opportunity costs, right? So that's related. And health insurance, we've also learned that health insurance provides a way to diversify financial risks associated with illness. And these markets are getting more and more complex, right? In the early days of insurance, it was very straightforward. It was like, you pick a co-insurance rate, you cover that rate, we'll cover the rest. That's it, right? And then today we've got all kinds of deductibles, co-insurance rates, co-pays, right? That's something that we didn't really talk about, are co-pays, which are flat payments for like doctor's visits. And so health insurance is just getting more and more complicated, which of course means that the analysis of it is going to be more and more complicated and provide lots of jobs in research in this realm, right? So that's good. If you want to be a health economist, there will never be a shortage of demand for your services. We also learned that firms that are selling insurance have important distinctions, right? Some are group insurance plans, others are selling to individuals, and we saw that the non-group type plans sold to individuals run into this considerable risk of adverse selection, right? The idea that sick people will try to pretend to be healthy people and get the better insurance at a lower cost, right? That's adverse selection. And we saw some solutions to this, right? And again, this adverse selection problem is coming from asymmetric information between the buyers of health insurance and the suppliers. But there are some possible solutions. The most notable one is perhaps the group insurance, right? With group insurance, you don't have this situation where bad risks can chase the good risks because it's provided typically through an employer. So that's one way to achieve that. Another way is through sort of a mandate, right? Community mandated or community rated insurance through a mandate. But that hasn't happened yet. Although that's kind of going on with Obamacare, right? So if you have subsidized ACA insurance, you're part of a group that is basically essentially community rated. So it's kind of happening, I guess, but it's not mandated. Like the government's not forcing insurance companies to do this, right? And in fact, they don't want them to do this. But regardless of the solution, whether it's employer-based group type insurance or this mandatory community rating, both the relatively sick and the relatively healthy might be better off, but it's also possible that the sick are made better off at the expense of the healthy, right? So we saw that with those PPFs essentially, right? The two different PPFs for the sick person and the healthy person and their indifference curves, right? That's what we were looking at there. And then as we progressed beyond that, we saw that these group insurances, when coupled with favorable tax treatment, has made insurance a popular but not universal fringe benefit. So again, 76% of people with insurance get insurance through their employer, right? So it's not total, but it's three quarters of people. And there are a large number of people that are still uninsured through either conventional employer-based insurance or individual insurance, or even Medicare and Medicaid. I'm actually one of those. Don't tell anybody. And many of these people are minimum wage workers, essentially. So that's something that we need to work on. And that was actually part of the ACA, was to target these types of people that are uninsured. They're not getting health insurance through their employer. They're not making enough money to pay for insurance on their own. But they're also not poor enough to qualify for Medicare, right? So they kind of fall in this gray zone where they don't really make enough money to buy their own insurance, but they're not poor enough to get it from the government. So the ACA was part of its mandate, part of its goal was to get these people on insurance somehow, and that's primarily through these public insurance marketplaces, right? Where you can, if your income's low enough, you don't get Medicare, but the government will pay for part of your insurance, right? And we'll actually look at that in the next chapter more closely. But just to recall, the two main provisions of the ACA is the mandate, which was actually repealed by Trump through, I think, executive order. So I'm not sure if that'll come back or not. I would imagine Joe Biden's trying to make it come back, since he was part of creating the ACA to begin with. And then it also prohibits discrimination based on pre-existing conditions, right? Whether it's higher deductibles or what is the word I'm looking for? Not giving coverage to people with those conditions at all, right? There's a better word that I was trying to find, I just couldn't. But again, we're going to look at these issues related to the ACA in the next chapter when we talk about the supply of health insurance and managed care. So that's it for today. Do you guys have any questions about anything for today? I know this was a lot of material, but y'all are smart. I know you can handle it. And so what I'll leave you with is just a little bit of a discussion of what we have left, right? So we've got 2 weeks of class left, four class meetings. So it's looking like we're only going to be able to cover chapter 11 and maybe a little bit of chapter 12, which is Medicare and Medicaid. I've been trying to decide whether to just skip the Medicare and Medicaid and instead cover the international comparisons, but I think it's really important to cover the Medicare and Medicaid. And I can kind of just give you some ideas about the international comparisons in, a couple of sentences. Basically, the summary is that in other countries, they mostly have nationalized healthcare, they have lower costs, and they have better outcomes. That's the gist of that chapter. So we're probably, unfortunately, going to have to drop that chapter, but I gave you the results in a very small nutshell. So that's what we're looking at next week, chapter 11, the following week, chapter 12, and then that's it. That's all for us. As far as homework for this chapter, I already posted it on Canvas, but it's problems 4 and 5. One of those is a particularly involved problem, which is why I only gave you 2. So one of them actually requires you to do a little bit of research. So yeah, have fun with that. But yeah, I only gave you 2 because the one where you have to do your own research is a little bit involved. So I didn't want to give you 3 problems. So yeah, so that's where we're at. We got a couple more weeks left and then we're done. So keep at it, keep doing the good job that you're doing, and y'all have a good weekend. I will see you on Monday for chapter 11.
Thank you.
Thank you. See you later.